and get started. So I'm hitting record. Welcome to our project scope session today. We're really excited to have you all here. If you've not attended one of our sessions before, just know that we are recording this ECHO session. By participating, you're consenting to be recorded. And if you don't want to, you can go ahead and disconnect. Our sessions will be on our Canvas site as well as on our website for later accessing. If you've never renamed your profile, please take a minute to do so by adding where you work, your first and last name. It just makes it easier for us to all learn and know who is on today's session. ECHO is a interactive community. We're hoping that you all learn something, but also connecting with everybody who is on the call. So we want you to be engaged by asking those questions and being able to provide feedback for the case narrative or case discussion that we will be having at the end of our session. Whenever we're talking about anybody or sharing a story, make sure to protect the individual's privacy. Avoid using any identifiable information. If you have any questions, feel free to reach out to a hub member. The hub members have an asterisk in front of their name on the call. The key components of an ECHO session are always to increase that community practice. We will have a didactic speaker, a case presentation, and then have some feedback for our case narrative or presentation. As always, you can pre-register for the ECHO courses by reaching out to Project Scope at USU, and you get a certificate of attendance after you complete those surveys. And we just want to thank you all everyone who has already filled out that initial survey. We do know that those first 3 surveys are kind of a beast to fill them out, but it gives us a lot of information and it provides us the ability to keep these sessions free of charge. So thank you to all that have filled those out already. You will all be getting a survey about today's session at the very today. Kurt, do you have anything that you want to share about surveys?
No, just thank you so much. We've had a better return than we did in the last iteration of ECHO. So thank you to all those who responded to my begging and pleading. It really does help us be able to have data that'll help us provide to other funders that may allow us to continue these sessions. So thank you so much.
Okay. I'm going to do another, just reach out for any case discussions. If there is a case discussion or something that you are just struggling with, would like to share with us, hear from your colleagues, please consider sending in a case discussion with it. Tressa is our hub member that is recruiting for case narratives and discussions. And so reach out to either Project Scope or to Tressa to let us know you're interested in doing that. I'm really excited today to have Heidi Dutson present to us about the Moving Prevention Upstream. She is currently the Prevention Program Administrator and Regional Director for the Utah Office of Substance Abuse and Mental Health. She just brings a wealth of knowledge and information, and I'm super excited to have us hear from her today. So just 2 more little plugs. Just remember, if you've not followed us on social media, we do share information on there, so feel free to follow us. And then a reminder that our next 2 sessions in April will be about neonatal abstinence syndrome as well as language development. So I'm going to stop sharing and turn it over to Heidi to take it away.
Awesome. Thank you so much, Janelle. I'm thrilled to be here. Give me just a moment here while I share my screen. All right, can you all see my slides now?
Yep.
Wonderful. Okay, so like Janelle said, I am with the newly named Office of Substance Use and Mental Health, and I work for our prevention team. And I'm really excited to consider some ways that all of you can understand some of the science and language. Some of you may already be familiar with it, but I always love an opportunity to collaborate in terms of language and the research that informs the very important work that we all do in helping to create healthy communities and families. Just a little bit of background. I've been working in prevention since 2009. I actually, when I was first introduced to prevention science, I took a sharp career pivot. I was in the insurance industry and always, had a desire to do something that was just a little bit more human related. And so I've been grateful since then. And by the way, my introduction to prevention came through a parenting class that a friend of mine twisted my arm to take. If any of you run programs, you can often know how hard it is to get people to actually sign up for those programs. I was a single mom at the time and super busy, and had a friend that ran this program and actually called me and said, "Hey, if I don't get at least 5 more people in this class, we're going to have to cancel it." Laid a good old guilt trip on me, and it was enough to get me to help her out, attend the class. And I fell in love with what I learned so much that it, like I said, actually led to a career pivot for me. So for a number of years, I ran a prevention coalition out where I live in Tooele City. A few years after that, I was able to take my work to the state of Utah, where I help mentor and provide training and technical assistance for coalitions across the state. Don't have any disclosures to give at this time, but I did want to take just a moment of reflection. If any of you are like any of the people that I know, including myself, the world kind of keeps turning up the heat as far as like the collective stress that is out there. We've all come quite a ways through this pandemic that we've all been enduring, and then enter, international crisis and all of the impacts of that to our neighborhoods, to our families, and to our own psyche. So I kind of like this picture because, I think a few years ago, I would have just felt this safe assumption that the man jumping here made it. But sometimes this can be us jumping from day to day or meeting to meeting, and this feeling like, well, am I going to make it? So I just want to kind of set this intention today for us to all kind of be in this mode of self-care and reflection. The concepts that I'm going to share with you today, the good news about them is that they're tried and trusted, and there will also be application in there for you to utilize today. And I have found some of the principles to be really helpful within my own life, within the relationships that I have in my family and my community. So there'll be a very personal application there as well as broader, and we'll talk a little bit about both. But to get us rolling today, I would like all of you, just in context of what we just talked about, with the world that we live in, to think about a child that you care about. Something I love about Project Scope is that you do these individual cases, that you come together around the one, about each unique person and individual. So I want you to think about a youth that you are concerned for, and just put in a chat a quality that you would like them to have as an adult, that you feel like they will need to navigate in the world that they live in. So go ahead and put those in the chat, just kind of as a reflection there. I'm seeing resilience, determination, resiliency again, trust. Oh, I love this one, the ability to ask for help. loving themselves, endurance, a sense of self-worth, executive functioning. Oh, I love this, Jetta, a sense of humor. That can be so helpful in navigating the world that we live in. Even a sense of being self-aware. Okay, very good. These are all really good qualities. Again, I hope that as we go, whatever the quality it is that you listed, or maybe there's others there that you notice that you would love to have more of, or identifying in others around you that need those. And to have a consideration of how can I use what I'm learning today to help build that quality in those that I care about. Okay, just quickly, some of the learning objectives. I'm going to go quickly through some data around opioids and give some resources for data. You know, there's probably many of you that are more of an expert on this specific data than me, but I will share some of that. And then we're going to kind of look at where we've been and where we are now, where we want to go when it comes to what we've done in terms of prevention strategies throughout time in our country. I'll introduce you to some science about risk factors that are linked to addiction and learn how to address them within our local communities. We'll also talk a bit about connectedness and some science related to that within our families, communities, and our peers, and how that helps protect us against addiction. And then we'll also talk about prevention environments and how we can nurture those in recovery, helping to end intergenerational addiction. So here's our first data slide. This shows our opioid deaths by drug category in the state of Utah. So you can see back in 2018-19, we were starting to build some confidence because we saw a substantial decrease there. And yet we're seeing those deaths on the rise again. You know, I think this is proof that, you know, the work in this area is never done. And, you know, whether it's physical or mental, environmental stress, that, you know, relying on the best research and the best work that's out there and coming together collaboratively around that is really important. This is the kind of data slide I love to see, these slippery slide data, that if you were able to, you know, hop on for a ride at the top of that and ride that down, you wouldn't be slowed down at all. This is showing the prescriptions that have been dispensed per 1,000 people. You can see we've come quite a way since 2014. The rate per thousand, they're reducing from 884 in 2014 to 622 in 2020. I'm curious what you all think has contributed to that decline. If you could just put some of those potential answers in the text box. Why have we seen a decline there? Okay, great. We're seeing doctors are becoming more aware. There have been policy changes. There have been, you know, campaigns and legislative actions even that have really encouraged doctors to prescribe less. They now have regulations on this kind of thing. More conversations are happening because of some of those campaigns and these limitations, right? There's more social awareness, there's more education, more regulation, and more open conversations. You know, I often compare when we see this kind of decline in the data back to what we saw with seatbelts. When I was growing up, I was the oldest of 5 children, and my family would load into I think it was like a 1980 Honda Civic. And the coveted seat in our family vehicle was always right on the emergency brake between my mom and dad. We'd go grab a pillow from the couch, put it out there, and that was the choice seat. I'd usually get it because I was the oldest. The second most coveted seat would actually be a chance to take a nap in the back window of our Honda Civic. And of course, times have changed since that time. And, you know, the reasons are parallel to what we just talked about with the opioid change. People looked at the data. They said, we've got a real problem here. We've got a lot of people dying in car crashes, and there is a way that we can prevent this. And so as the science behind that and the social awareness of that made it to legislature, pretty soon we had laws implemented to a point now that we have a culture that if we were to see a family probably driving down any freeway or main street in Utah, I would venture to guess it wouldn't take them very long before they were pulled over by a law enforcement agency, or if somebody would call very concerned and at least react to that in a way that would be shocked and disapproving, right?
Before you move on, there's just a question on there that is asking about that data. She's wondering, am I understanding the data correctly that in 2014, 884 out of 1,000 people received a prescription for opioid drugs?
Yes, so this is, I'm glad she's asking that question, because I was going to clarify on the rate number. I pulled these numbers off of, I actually put it on the last slide. As I understand it, that yes, that this is a rate of prescriptions dispensed. And so out of 1,000 people. So I am actually not sure if that means 884 people that were prescribed medications, that it was an opioid, or if that rate is identified by some other means. But I appreciate the question. And if you want to email me, I'd be happy to send you on the clarification. Do want to indicate here, though, that rate is decreasing. And of course, those numbers are still much higher than what we would like to see. And so we have a lot of work to do. Well, when we talk about prevention in the division and the office that I work within, a term that we often use is that we want to move upstream. Some of the data that I just gave you, you know, is what we see evidence of in our communities. And when we see and hear of an opioid death or a hospitalization, when we know that children have been born with addicted to opioids, these are some of the very triggering and emotional reactions that we have. We see that we have a problem. And in upstream prevention, we often talk about a parable that I'd like to share quickly with this audience today. The parable goes something like this. A man and a wife are out fishing. They're enjoying a lovely day of recreation. And before being out there too long, they notice that there is somebody down in the water and they are struggling to breathe. They're struggling to swim. And of course, reacting to this emergency, they put their fishing pole aside, jump in the river, and go to help this person that is struggling. They call the ambulance, connect that person to the right help, and resume their recreation. And before long, they see another person coming along that is likewise struggling. And before long, they find that they're spending most of their day, most of their time and resources pulling people from the river. Well, what upstream prevention begs us to ask is, why are all of these people struggling in the water? And what happens if we go upstream? What might we find? And so let's just say that upstream, you know, there was a slippery cliff, and we noticed that people were walking along and dangerously falling off of a ravine. You know, is there something that we could do there to prevent people from falling in the first place? Could we build a fence or post signs that would help people avoid the danger here? So that is what we want to consider when I say that we're talking about upstream prevention. We're talking about how can we, take that hike upstream so that we can create environments in our communities, in our families, in our home, so that we are preventing the risk of that happening in the first place. I love this quote that comes to us from the IOM. It's from 1994, but still true today. It says, infusing a prevention focus into the public consciousness requires development of a shared public vision and attention at a higher level than currently exists. And I love this quote. I love that it's from 1994, because this is really when we started to see this real need for a focus upstream. Words like, we have a drug epidemic, conditions that were there in the 80s, and people were searching for what's happening here and what can we do about it. So it presented a real need to move upstream. We know throughout time there were lots of different strategies tried, all well-intended, and maybe you've seen some of these in your communities as well. We know, for example, during the Reagan years, bless Nancy Reagan, because she cared about this and she wanted kids to not use drugs. And her campaign became this theme of, hey, just say no. And did that work? Unfortunately, although well-intended, we actually saw drug rates increase under this campaign. So while well-intended, just that tagline alone or that instruction perhaps wasn't enough. We've also tried, educating our kids, helping them understand. We've had some school programs that, we're going to educate them. We're going to pass around drug paraphernalia or show them horrible consequences or images of what drug use can do. I have a colleague that says this approach is called scaring the health out of kids and into kids, right? Scaring the health into them by scaring the hell out of them, right? But we've also seen that this strategy isn't always effective, and in fact, sometimes can make rates increase instead of decrease, and can do more harm than good. So what has prevention science taught us that actually does work? For this, and what I want to talk about today is 3 pillars of prevention. Something we really rely on is the science of risk factors. We see, for example, in the public health model, say with heart disease, we know that if we maybe eat a certain high fat diet or become couch potatoes, we're increasing our risk for cardiac disease. Likewise, if we know that we're at risk for a heart attack, there's things that we can do to buffer against that risk or to protect us. We can put down the bacon for healthy vegetables, and we can increase the exercise that we're getting. All of those things, even if we have a high genetic risk, are going to help buffer against the risk that we have. Good news is that there's been about 4 decades now of prevention science that have helped us to identify what some of these risks are and how we can buffer against those. And then, of course, we know that we need the very best of evidence-based programs and strategies then to address those risk and protective factors. Just so that we're clear what those are, a risk factor is anything that predicts the likelihood of drug use, delinquency, school dropout, and or violent behavior, or other undesirable behaviors. Protective factors then exert a positive influence, the opposite. And there's that word again, it's going to buffer against the risk, which will then reduce the likelihood that an adolescent will engage in these problem behaviors. So here's our risk factor chart. And there's a lot to take in here on this chart. I'd be happy to email a copy of this, and I have included the website where this research comes from in the resources for today. But what I want you to notice here is that everywhere that there is a check mark, that indicates that there have been at least 2 qualitative and longitudinal research studies linking the risk factor to the problem behavior. You'll also notice across the top, we have divided out all of those risk factors into 4 different domains. We know that some risk comes from families, some risk kids don't encounter until they start going to school. Some are inherent within the communities that they live in, and some are present either within their own constitution or as they interact with peers. So again, anywhere that you see a check mark, that indicates that there have been at least 2 qualitative, excuse me, and longitudinal research studies linking that behavior. I would like just any comments on this chart or anything you notice. Let me ask you this question: which domain has the most check marks in it, percentage-wise? Okay, I see somebody bringing up violence there. There's a lot of check marks clear across the board there. Great. Lots there for substance use. And then look across the top, and by domain, I mean, we've got community, we've got family, we've got school, we've got peer and individual. Percentage-wise, there are a lot of risk factor boxes that are checked there within the families. Do families matter? Absolutely. A lot there in school as well. Can we create environments where we can reduce risk factors in schools? Which one of these are the most important? I would love to hear out of the domains. Which one do you think they can have the most impact? I'm seeing family. Family and peer. Great. Cool. And that question really wasn't asked in a terms of there's one right answer. We know that anywhere that we can reduce risk or increase protection, that it's going to be helpful. But certainly kids start out in their family. And I'm guessing all of you as professionals, you have some degree of experience in seeing these impacts when these risks are high. Perhaps it's, exposure to previous drug use within the family that increases the risk. And so the sooner we can start with those interventions and buffering against that risk, the greater likelihood we're going to have to get this child, the adolescent, to a healthy adult stage in life. I'm going to go ahead and advance from this. If any of you are interested, by the way, in more discussion around these charts or these risk factors, we do have trainings that take a lot more time than I have today to go into more depth, but I'd be happy to connect you with those or to have an orientation about them. So this is our protective factor chart that buffers against those risk factors. The ones that I've circled in yellow here actually have a shared correlation between substance use and depression and anxiety. And sometimes that can be really interesting to look at those relationships with mental health and then also with substance use. What I'm going to spend the remainder of our time talking about today is actually a strategy that is protective and has been shown to buffer against some of those risk factors. And like I said at the beginning, I find this strategy really exciting because it's something that we as individuals, as family members, and community members can implement every day. So the understanding behind the social development strategy is that all of us want to help our kids achieve healthy behaviors. We mentioned several of these in the chat when we started this presentation today. We want our kids to have that sense of self-worth. We want them to have self-determination, to be resilient, to have good sense of humor, and to be able to employ all of those characteristics that are going to help them to succeed in life. So the developers of this research, Dr. Hawkins and Catalano, wanted to answer the question, how do we get kids here? What are some of the ingredients that are required? And the first thing that they came to understand is that kids really need a sense of healthy beliefs and clear standards. They need to know where the boundaries are. They need to know what the rules are. And that became very evident. But then they asked themselves the questions, okay, wherever there's a rule or a really clear standard, will it always be followed? And of course, we know the answer to that is no, to the term that people very often understand that phrase, rules were made to be broken, right? And so then the question became, if we have really healthy beliefs and we have really clear standards around what those are, what makes a difference whether a child adheres to those standards or doesn't? And what they found is that the kind of the secret sauce with that is what we refer to as bonding, this sense of attachment and commitment within this group. And interestingly enough, because we understand the need for that usually intrinsically within families and relationships, but bonding can also happen at school and within our communities and within peer groups. Well, they wanted to dig even deeper because kind of intrinsically, we know what bonding feels like. It's kind of that warm, fuzzy feeling, but how do we create that? Beyond big hugs and chocolate kisses, how do we create that sense of bonding? And what the science shows is that any time that we provide an opportunity to teach skills and then provide appropriate recognition for what is learned and taught, we are building a sense of bonding. And then, of course, with that, we need to nurture an individual's characteristics. If any of you are visual learners like me, this is another way to look at the social development strategy. You see in the healthy horizon there, these healthy behaviors. To have a clear path, we need those clear rules, but we have to make sure that we have the bonding. And those 4 squares there indicate all of the different domains. And then kind of those flagships there on the left, we need opportunities, skills, and recognition. So here I want to just underscore the really great importance of being clear with the standards. This was illustrated to me as a mom when one of my children started to play t-ball. I don't know if any of you have had the chance to watch a t-ball game. It can be so entertaining watching these young people learn this sport for this first time. And my child was so excited to get his opportunity to play t-ball. He had been to practice, he was prepared, he had on his cute little uniform. And at the first game we went to, he was so excited for his first chance up to bat. So this son of mine, his name was Brock, he got up to bat. Man, he eyed that ball, he squared up, he swung and he hit that ball off the tee and took off running. Well, me as the mom, I was standing outside the fence along the first baseline and noticed as he approached first base, he ran around the base and kept running to second. Of course, for me, understanding the rules of baseball, I started yelling at him from the sideline, touch the base. You need to touch the base. With which he looked back at me with this confused look of, why are you yelling at me like that? He got up to, once he'd made it around the bases and his turn came again, he got up to bat again. This time, to avoid his mom or his coach yelling at him from the sidelines, he hit that ball off the tee and went running towards first base. And then this time, very obviously, so I would see it, he took his hand and touched the first base. so that he could follow his mom and coach's instructions. Now, this really illustrated the lesson to me, in that sometimes as parents, as school teachers, as people in the community, we think that we're being really clear. His coach had been clear with those kids that when you get up and you hit that ball, you run around those bases just as fast as you can. And he had done that. And then after he had done that, as the mom, I'm yelling at him from the sideline, touch the base, to which he did with the hand, which is most often what he was taught to touch things with. So poor Brock finally got the rules straight that day and learned that he needed to tag the base with his foot once the adults in his life learned to communicate in a way that made those standards clear to him. So I invite all of you to think about, in your different domains and the standards that we're expecting of our kids, do they really understand what that looks like? Do they know what we mean and why we mean it? Say around things like opioids. Recently I had a son that had his wisdom teeth out. And before the procedure even began, my son was given a prescription for 7 days of opioids, should he need those. Without a clearer understanding of what the potential harms of those drugs would be, I might just assume, you know what? The doctor wants you to take these. You need to take these every single day. My child might misunderstand that was a requirement instead of something that was optional and only necessary if you really needed those for pain. Okay, the next parts of that are opportunity, skills, and recognition. So another quick story about this same kid. A few months before the baseball story, as a toddler, he found himself, maybe is more like preschooler, anytime that he would get sticky, he would have an absolute fall apart. This was very triggering for him. And anytime we had pancakes or waffles at the breakfast table, he would go into an all outfit if he got any of that sticky, syrupy substance on his fingers. Sometimes it would take him over 30 minutes to calm down. Well, my dad, his grandpa at the time, came up with a solution. And little did he know, he was actually employing the social development strategy. And what his grandpa decided is that he wanted to take him on a special grandpa-grandson date. And at the time, we lived near some hot pots in southern Utah. But before they went to the hot pots, they stopped at the grocery store and they got every sticky thing they could think of. They got root beer, they got Hershey syrup, they got ketchup. And my dad took him to the hot pots and proceeded to, for himself, open a can of root beer and dump the root beer over his head. And then he did the same thing with the other substances, all along the way saying, hey, Brock, you know what? Sticky can actually be fun. Look, this is kind of fun. Then he'd take the warm water and wash it off. Well, after my son got over the shock of that and looking very curiously at his grandpa, he decided to join in on the fun. And here he is at 4 years old, raising cheers with a can of mug root beer because he had learned how to conquer being sticky and making it fun. And by the way, through subsequent years, and days, even the next day after this, when he found himself feeling sticky, he would reiterate what his grandpa taught him. Sticky is fun. Sticky is fun. And it became a great coping mechanism and has since become a great metaphor for life. This child has actually grown now. He's married and he's a father of an adorable little boy. And so he often reminds himself when life presents sticky situations that it can be fun. And if we apply the very best skills that we have, that we can get through those things. So we have Grandpa to thank for that. And even though he didn't know the social development strategy, you may be able to identify times in your life where people have done something similarly. Did they find an opportunity, like my dad did, to teach a skill? Let's teach a resilience skill. here, and then give them recognition, just like we did with Brock. Every time he handled a sticky situation, good job, bud. Look at how you're handling that. Way to take a deep breath and to remember that sticky can be fun. So again, I invite you to think about different ways that you can incorporate this, whether that be with clients, within your family, or within your communities. When it comes to our community, we know, that sometimes we feel like we have a big lift or a big push to reduce these risks and increase the protective factors that we have in our community. So we know that no one person can do it alone. If any of you have ever had to push a car that isn't working well all by yourself, we know that that is laborious, and it's a lot easier the more help that we have. I found these images kind of humorous and relate them to what we need in our community. We have a lot of change that we want to see. So the more people that we can get involved with that, understanding the options, the programs that are out there, the science behind it, the better off that we will be. Throughout Utah, and I've put our website here, utahprevention.org. We have coalitions that are organized, and they use these research-based frameworks. The first part of that is that they are going to assess their community and really dig in and find out what are the risk factors that are present in their community, what protective factors are really decreased, and what needs to happen. They lean very heavily, if any of you are familiar with the SHARP survey that's administered in all Utah schools, they're able to look at that data and really have that assessment. Then they know that they need to build capacity within the communities to do the work that they need to do. Do they have buy-in from stakeholders and key leaders and community members? Do they have the resources, the manpower, the office space that they need to make this happen? Then they go through a series of steps to do some planning before they can implement. And of course, an important part with implementation is making sure that they're using fidelity to the way the program was studied and proven to be effective. And then of course, there's a period needed for evaluation. Did what we set out to do work? And did it work the way that we planned it to? What lessons did we learn? If we had to do this again, what changes would we make? So I invite all of you to go to that website, utahprevention.org. Wherever you are in the state of Utah, there's a prevention coordinator that has at least one coalition. Some areas like down in Utah, or southern Utah, we have several coalitions that are really customizing their coalition efforts to the unique populations that they serve. I mentioned at the beginning that something we want to talk about here is stopping the cycle. Within our opioid prevention campaign, this is something that we talk a lot about, that we need to start the healing, to have conversations with our doctors, have that conversation earlier, get on the prevention end of things and be great advocates and heroes for kids in that sense. And one of the things I love is when early upstream prevention coincides with people that have learned the hard way about addiction. So often we will see those in recovery want to join our coalitions or to reach out to kids and say, I just want to stop this from happening. The good news there is it's the very same research that we just talked about in the social development strategy that informs the very best approaches for them to use. Often people in recovery think that what they need to do is go out and tell their story and the nuts and bolts and sometimes guts of their addiction story. Well, oftentimes this can be akin to the scare tactics that we have actually seen don't work. But what does work? Ironically, it's often the same things that they learned in recovery, to pass on helpful skills like how to manage stress, how to deal with strong emotions like anger. What are healthy coping skills? And again, all of those things, if you recognize that language, Find those opportunities to teach a skill and then give recognition. When we do that, we're creating a sense of bonding that then will help our kids and adolescents adhere to the standards that are set for them, hopefully in all of the domains of life. And so when it comes to drug addiction, we want those strong standards in our families, and we know that they're already there within our schools and our communities. Okay, Know Your Script is our Utah prevention campaign specific for opioids. You can visit knowyourscript.org to learn more about that. But of course, we want to be informed consumers and help those that we care about ask the questions like, how am I supposed to take this medication? Are there safer alternatives? Is there a risk of dependency or addiction here? What do I do if I miss a dose? Should I avoid anything while taking this medication? And what would be a plan to taper off of these? Reflecting on my example there with my son and the dentist, all of these were appropriate questions and things that I needed to talk to my son about to make sure that those were used appropriately. To close out today, I know that was a lot that we covered in a really short time, so I welcome you to reach out to me if you have any questions, but wanted to leave you all with this thought. Do not be daunted by the enormity of the world's grief. Do justly now, love mercy now, walk humbly now. You are not obligated to complete the work, but neither are you free to abandon it. So big thank you to all of the good that you do in your individual work and responsibilities. I've left some references here at the end of the slides, as well as my contact information there. And with that, I'll turn it back to Janelle. Thanks again for having me.
Heidi, that was a great presentation. Thank you so much. I love that it is just a great way to think about moving that prevention upstream. And as early child care providers, when we listen and support families, we're really helping create that social awareness amongst everything. So great. I'm going to give us a few minutes to ask Heidi any questions. If you have any, feel free to just come unmute or put it in the chat and I will ask her. Those awkward pauses on Zoom when we're all waiting.
Janelle, while we are waiting for questions, I did just put in the chat the link to that opioid data. It's a super helpful dashboard, relatively new. I don't know if any of you work specifically with that, but there's all kinds of data available specific to Utah around opioids on that website.
Great. Okay, well, Heidi, there are no questions. So thank you so much for your time and taking that time to share with us the moving upstream prevention. We are going to now have Lisa. And Lisa, even though you told me your last name, I'm not going to even try. So Lisa, I will go ahead and share your case narrative and you can start. Can everybody see this?
Okay. Well, it's Lisa Savetnik, and I know nobody knows how to pronounce it, so that's okay. But I am one of the special ed teachers in the Jordan Child Development Center, and our program covers both Jordan School District and Canyons with their Birth to 3 program. So you can go ahead and go to the next slide. I am presenting today on a little kiddo that I haven't been seeing her too long, actually. She is 19 months old right now. She is living with biological grandparents, along with an older biological sibling and a baby brother. These grandparents have already adopted the older sibling, and they're going to adopt the 2 younger ones next month. this little girl, she mom during pregnancy took meth, heroin, illegal Suboxone, and she did get treatment, but it wasn't until about a month before this little girl was born. Once she was born, she was in the NICU for about 3 weeks just due to withdrawal and breathing issues. Grandparents noticed that for about a year afterwards, she still had, they call it her shakes. So they just noticed like she would shake throughout the day. She had little tremors. When I evaluated her to see if she qualified, she actually did not qualify based on her BDI scores. But her grandparents, who will be her adopted parents, they were actually really concerned with her because they were noticing some behavior. So even though she's using lots of words, she's understanding, she's following some simple directions. She's really social. She's super engaging. She plays with toys well. So even though her BDI scores looked good, when we talked about some of the things that the BDI doesn't hit, that was enough to where we felt like we needed to see her in early intervention to work on some of those other things that we were seeing. You can go to the next slide. So the biggest areas that the family's concerned about right now have to deal with regulation. So this is a very dysregulated little girl, and it's having a big impact on just a lot of the family's day. So sleep-wise, she still needs her parents to rock her to sleep. If they try to put her in her crib, she'll bang her head, she screams, she cries, she just cannot settle herself enough to go to sleep. And she's also still waking up multiple times per night. Parents also report that she still does that startle awake like you would see with infants. So she's still doing that. Part of the sleep is due to a regulation issue. Part of the sleep is that the parents also like rocking her to sleep still. That's kind of part of their nighttime routine. It's just comforting to them as well as to her. But that's something that they do want to start working on. Behavior-wise, this little girl gets very upset. She kind of goes from 0 to 60 pretty quickly. I haven't seen any, but family reports she has some breath holding episodes. She is very impulsive. She's very fast. And like I said, she's 19 months old, so she's tiny and she's fast. She's very unaware of kind of what's around her. She's constantly falling, bumping into things, tripping. She will, instead of like sitting down and turning around to get off the couch, she will just step off the couch. So things like that. She does not slow down when she's around stairs. So everything, she has to be just constantly supervised, which is hard. And then also transitions are really hard. So anytime she has to move from one activity to the next, that's also really hard for her. She's a pretty picky eater. This one I haven't been able to tease out though, whether she's just kind of toddler picky, because she hates to kind of sit down and focus on something. The family just kind of feeds her bites here and there when they can. So the last time I was there, she did say eat. So she was playing and she wanted to eat something. And so mom brought her over, I think it was yogurt or cottage cheese, and just kind of like spoon fed her a few bites as she was playing. So the family just kind of feeds her wherever she is. But she was able to ask for food when she was hungry. But you know, she's, like I said, she's just very dysregulated throughout the day. And of course, that's going to impact her sleep behavior and eating. But in spite of all that, her language and her play skills look pretty good. So she does have some good skills kind of mixed in with some of those big areas that the family's concerned about. So you can go to the next slide. Okay, good. I did take her name out. I was worried about that. So kind of some of her IFSP goals align just with the things that we were just talking about. So the family does have a bedtime routine. However, they want to change that up a bit so that she's moving towards developing some better sleep habits, starting to fall asleep on her own, and then being able to stay asleep through the night. Part of it, like I said, parents love rocking her to sleep and being a part of that. But then they also have to multiple times throughout the night go back in and settle her back down. She's very, she moves a lot throughout the night. And so she kind of gets into awkward positions. And so that might be a reason she keeps waking up. Also, she's used to parents putting her to sleep. So when she wakes up, I think she wants that repeated to help her fall back asleep. So establishing kind of a new sleep routine. They also want her to start being aware of things that are dangerous. So either by avoiding them or at least checking in with an adult before approaching them or touching something. And then also following some directions related to safety, such as stop, come here, give it to me. So those are some of the IFSP goals that the family wanted to start working on. Barriers to the goals, like I said, she's really dysregulated. She is constant motion until she drops, until she's tired and just falls asleep kind of wherever she's at. Her parents are really busy. Like I said, they're biological grandparents, so they're in their mid-60s. They're still working, and they have 3 young kids. The older sister's in school during the day, but then the 2 younger ones are at home. They are lucky enough, they have a good nanny that is there throughout the days, but the nanny also gets very overwhelmed because there's the toddler and the baby, and both of them are in our program, and they're both a lot of work. And then also parents aren't just sure kind of what to expect. They know that she was exposed to drugs, but they're not kind of sure what the long-term impacts of that is going to be. So starting out, we did start putting in a few strategies that the parents are working on. We started building in quiet time into the daily routine. They wanted to jump right into sleep, but where we started was just teaching her how to go from higher activity levels to like a moderate activity level to kind of calm and quiet. So like a playtime to a snack time to a resting time. And like I said, we started working on that outside of nap and sleep just to start teaching her what that looks like. Because like I said, she is very go, go, go until she drops. There's no sort of, sometimes I sit and I'm quiet and I play. Other times I'm up and more active. She's just always really busy. So we built that in to start kind of teaching that self-regulation. So the nanny twice a day will create a quiet time. So she, turns off lights, she puts toys away. The little girl gets a blanket or like a stuffed animal. The nanny kind of models having a quiet body, a quiet voice. And that lasts maybe 2 minutes. But that's kind of the goal, is just to teach her from going from being active to kind of working through those kind of moderate and then low activity times. We also started building in some heavy work for this little girl throughout the day. Like I said, her body awareness is it's just not there. She's just running everywhere. She's constantly bonking into things. She's tripping, she's falling. She's just not paying attention to things that are around her. But she does like to kind of carry things and move things. She pushes her little plastic slide around, and that was really nice because one, it slows her down. So she kind of, she's moving a little bit slower. Plus, if she's carrying something like a pillow, or she's pushing her slide, or she's moving her toy basket, she's having to kind of make these weight adjustments, and it's slowing her down, and she's having to like really, push her heavy little toy basket to where she wants to play, to give her some good input through her, just her muscles and joints. And again, just to kind of slow her down and make her more aware of like what she's doing with that toy bin, where she needs to push it, where she needs to go, what's in her way, what she needs to kind of navigate around. We've also talked to the family about decreasing distractions. So they're actually pretty good about not having screens on until it's necessary. But, kind of thinning out the toys, thinning out the books, just having a few things for this little girl to do instead of just a really busy living room. Parents have already kind of put in some safety measures as far as gates and locks to help keep her safe. And then we've started working on some, helping her follow some clear, simple directions with follow through if needed. So something simple like, put your plate in the garbage, or, give this to mom, just kind of simple things, get your shoes, just to kind of help her become aware of and participate more in those routines that the family has already set up. So actually this family is pretty good. Like I said, they already have a pretty predictable routine. We just kind of need to make some changes to it to help kind of with that regulation piece. So what I would love feedback on is just about some additional strategies to help with this little girl's impulsivity and teaching safety. Again, she's little, so she's 19 months old. So kind of keeping in mind that she's a toddler. Any additional information about how to teach that regulation? Again, we're already doing a predictable schedule. We're building in some time where she's getting heavy work. She also really loves kind of those deep pressure, that's those squeezes. She asks for it, but she'll hold out her arm or hold up her foot. So she really likes that one, and that's very calming for her. But anything else related to regulation, and also just resources for the family as far as, support groups, helping them understand, appropriate behavior strategies. And then, like I said, they also want more information about how drug use can impact, behavior and development now and later on. They're already seeing it with older sister, but again, just any other additional resources, any support groups that are out there for families.
Oh, go ahead.
Go ahead.
No,
Go ahead. I was just going to share, we had a sleep therapist come and present to our agency and went over some of the brain science that goes on during the night. And especially for any children that have like really strong or don't have deep sleeping tendencies and have arousing tendencies during the night. They said that their routine into bedtime is really important, because if you go from one thing and then change how they fell asleep and they wake up to a different environment, their bodies are more likely to arouse awake completely instead of just do a mental check-in and go back to sleep. And so making sure that how the child fell asleep is how their check-ins are in the middle of the night. And I don't know, maybe like a sleep therapist to really dive into her unique situation and regulation might help to, help with her energy and her regulation during the day if she's getting that appropriate sleep through the night.
Yeah, and I think this is a situation where like the parents know they've sort of set up that like sleep, like they love the rocking her to sleep. She loves it. It's a very like social time for them. They're not quite ready to break that yet. And so that's why we're working on it in other times during the day. But we have talked about like that rocking is great and keep that, but she goes into her crib eventually. That's our goal, is that she goes into her crib awake, but calm. And so, those nightly check-ins might be one of the parents just has to kind of go in. They don't have to pick her up and start that whole thing over again. They're just in a moment right now where it's like, we need everybody to sleep however they can. And so I think like when they're ready, yeah, they'll be more willing to like work on, okay, how do we help her fall asleep without us doing it? Yeah, thank you.
Yeah, there's already some great things in the chat, and we'll put those on your recommendation sheet too. There is one question. It says, has she seen a developmental pediatrician like Dr. Winters at UDAC?
I don't believe so yet. I'm trying to think of who else they've seen. I think we were the first call. But I don't know. I don't think they've done any sort of evaluation up at UDAC yet. But that might be a good recommendation. I'm not sure what all else they would look at, but like I said, this is a little girl, like developmentally, if you just looked at her testing from EI, you'd be like, oh, she's doing great. That's awesome. And, luckily these parents were very much aware of like, there's other stuff going on. And so, like I said, we went ahead and qualified her for our program.
Okay.
Oh, but I see the grand families.
Yeah.
I haven't ever heard of that. Is that something that's also in Salt Lake County, or is that?
So, Lauren, do you have more information about grand families that you would like to share? So, okay. Are there any other questions before we move into breakout groups to ask Lisa? If not, we want to make sure that we help her think about impulsivity and teaching safety awareness, teaching regulations, resources for the family. Each hub group breakout group will have a hub member in it, so make sure you assign or take notes. And then we will hopefully have time to come back together and talk about one strategy from our group. If not, they are always on the Canvas site. So any other questions beforehand? Okay, then we will go to breakout groups until 1:25. Bailey, did you start the breakout groups?
Yeah, I just opened it.
Okay. Welcome back, everybody. Bailey, do we have everybody back?
We're just waiting on one group,
Okay.
but there's 10 more seconds till they're automatically brought back.
Okay.
You're good to start.
Okay, so welcome back, everybody. I hope you guys had great discussions with those. If you would, your note taker or whoever you had take notes, send those recommendations into project scope at usu.edu and we will compile those. We are running short on time, so we probably don't have enough time to go over one idea from everybody, but Lisa, we will send those individually to you as well as they will be on our Canvas site.
Thank you.
So sounds like some great discussions. Just once again, another reminder that our April sessions will be on with Dr. Camille Fung around just the introduction of NAS and NOWS, as well as language development. So that will be in August if you have, April, not August. I'm already done with summer. April. So we will see you guys then. Thanks for joining us today.